Hey everyone, this is Dr. Medicine Alex, and in today's video we'll be discussing about pemphigus and its variants. So before going deep into the clinical features and the investigations and treatment, we basically need to understand what the basic pathology here is. So the basic structure that is affected in pemphigus is the desmosome. So desmosomes are nothing but the intercellular junctions that help attach one cell of the epidermis to the other cell. So they are basically present between two keratinocytes of all the layers of the epidermis. That includes the corneum, the stratum corneum, the stratum granulosum, the stratum spinosum, and the stratum basale. These desmosomes, in their ultrastructure, they have certain molecules. These includes the desmoglines, the desmocollins, and the placoglobins, desmoplakins, and the placophilins. So these ultrastructural molecules are really important in maintaining the structure of the desmosomes, and these are the basic target proteins that are affected in various types of pemphigus. Desmoglines, they are again of 4 isoforms. But the two main isoforms that are important in pemphigus are the 1 and 3. The desmoglein 1, it is located more in number in the upper epidermis, whereas the desmoglein 3, it is located more in the stratum basale. And the desmocollin, it has 3 isoforms. However, similar to desmoglins, the desmocollin 1 is located more in the upper epidermis, whereas the desmocollin 3 is located in the stratum basale. Similarly, the placoglobins, desmoplakins, and placophilins, they connect the intracellular portions of desmoglein and desmocollin, as is shown in the picture. So coming to the various proteins that are targeted in various types of pemphigus. So Pemphigus vulgaris and Pemphigus vegetans, the desmoglein 3 is more commonly affected, but desmoglein 1 is also affected. And in Pemphigus foliaceus, as well as the endemic Pemphigus foliaceus, that is a Phogos selvagem, and Pemphigus erythematosus, desmoglein 1 as well as the desmocollin are affected. Then in Pemphigus herpetiformis, desmoglein 1 is affected more than the desmoglein 3, whereas in vulgaris and vegetans, both are affected. Then in IgA pemphigus, we have again two types, the intraepidermal neutrophilic type and the subcorneal pustular dermatosis like type. And in this, the desmoglein 1 is more affected, as well as the desmoglein 3, and more importantly the desmocollin 1. Then in paraneoplastic pemphigus, in addition to the desmogleins, we also see the plakins as well as the bullous pemphigoid antigen 1 being affected. And in drug-induced pemphigus, both desmoglein 1 and 3 are affected, but desmoglein 1 is more affected than desmoglein 3. Now coming to Pemphigus vulgaris. So Pemphigus vulgaris is again of two types, the mucosal dominant variant as well as the mucocutaneous type. Mucocutaneous type is commonly encountered. Well, as the name suggests, in mucosal dominant type, the mucosal erosions are more common and there is minimal skin involvement, whereas in the mucocutaneous type, both mucosa and skin are affected extensively. So we also see skin blisters and erosions. Coming to the clinical features, so it usually begins as asymptomatic vesicles, bullae, and erosions on the skin, and we also see erosions and ulcers on oral mucosa. Usually the oral mucosa is first affected, followed by the skin. So the common sites which are affected include the head, the neck, axilla, trunk, groins, and pressure points. And the blisters, they are flaccid and they rupture very easily, and they have clear fluid. However, if there is any turbidity or if any purulence are seen, then it is because of a secondary infection or because of also the cellular debris. So the larger bullae, they tend to have turbid fluid which settles down, and the clear fluid, it moves up, giving the hypopyon sign. So whenever these bullae rupture, they form erosions, and these erosions, they are associated with pain because the nerve endings, they become exposed, and these erosions, they extend onto the normal skin, which is what we try to elicit using the Nikolsky sign, and they have an offensive odor and they become crusted, and they heal with hyperpigmentation and there is no scarring. Coming to oral lesions, the oral involvement is seen in almost all patients, be it the mucosal dominant type or the mucocutaneous type. We see oral lesions in almost all patients, and the sites affected in the oral mucosa or the buccal, the palatal, and the gingival mucosa. So the lesions, they are more superficial, but they are very painful and they are very persistent. They can occur as erosions, or they can be ulcers, or they can be collapsed bullae with a grayish necrotic slough. However, they do not resolve spontaneously, and if they are extensive, then they are going to cause a lot of pain, leading to decreased intake of the food. And this again, it leads to weight loss as well as hypoproteinemia. And they can also predispose to, since there is a damaged barrier here, they can also predispose to superimposed candidal infection. Other mucosal surfaces that can be affected in pemphigus include the ocular mucosa, where there can be redness and photophobia, the genital mucosa, where vaginal erosions cause dyspareunia, and then rectal mucosa can cause, if affected, can cause pain during defecation. If urinary mucosa is involved, then burning micturition can occur. If nasal mucosa is involved, there can be epistaxis, and if laryngeal mucosa is involved, there can be hoarseness of voice and throat pain. Nail changes, there can be acute paronychia, subungual hematoma, and onycholysis. Now coming to Pemphigus vegetans, which is a variant of Pemphigus vulgaris, it is very rare, and compared to Pemphigus vulgaris, it is more benign. So it again has two forms, the Newman type and the Halopo type. So the Newman type, it is like it progresses into the Halopo type, where initially there are going to be vesicular pustules, which later become vegetating lesions. So the lesions, they appear ab initio, or they can occur over pre-existing Pemphigus vulgaris lesions. And there are other variants like the tumid variant, the vegetating variant, the papillomatous variant, and the hypertrophic variant. The common lesion, the primary lesion that we encounter is a plug, which is seen in the intertriginous and flexural areas. And because there is local moisture and heat and friction in the intertriginous areas, these lesions, they can be recurring or they can be recalcitrant to treatment. Another important sign that is associated with Pemphigus vegetans is a Premlata sign, where there are changes, characteristic changes on the tongue, leading to a cerebriform tongue. And there can also be vegetating granulations in the oral cavity. Coming to Pemphigus foliaceus, here the target antigen, it is desmoglein 1, and this sort of explains why the oral mucosa is not involved in Pemphigus foliaceus, because in oral mucosa the desmoglein 1 is expressed at a much lower level, in lower amounts compared to the desmoglein 3, and that is why the desmoglein 3 kind of compensates. Therefore, the oral mucosa is usually not involved in Pemphigus foliaceus. So, the small flaccid bullae with crusting and scaling are the characteristic lesions in Pemphigus foliaceus. So, the initial lesions, they are sharply demarcated and they characteristically involve the seborrheic areas, which may become generalized and can cause erythroderma. So, the erythroderma causing type of Pemphigus is the Pemphigus foliaceus. So, the initial lesions, they occur as scaly moist papules or superficial flaccid bullae that rupture to form moist erosions with cornflake like crust, and there is a characteristic musty odor, and the Nikolsky sign is positive, and it has a chronic benign course, but there can be intermittent crops of lesions. Now coming to Pemphigus erythematosus, so the erythematosus is characterized by the presence of scaly plaques and thin-walled bullae with denuded areas on the butterfly area of the face. So this is a localized variant of Pemphigus foliaceus, and on histology it resembles Pemphigus foliaceus, and the lesions also can occur over the back or the chest or the intertriginous areas. Coming to Pemphigus herpetiformis, so this is a rare variant. In most, it is a clinical variant of Pemphigus foliaceus. In some, it can be a clinical variant of Pemphigus vulgaris. So the target antigen here is desmoglein 1 as well as desmoglein 3, but desmoglein 1 is more commonly affected. And more recently, other antigens have also been detected. So as the name suggests, herpetiform arrangement of vesicles is seen. These are flaccid vesicles, and it is associated with pruritus. So it resembles dermatitis herpetiformis, and it runs a chronic course, and it can evolve into Pemphigus vulgaris. And the lesions, they have eosinophils with or without neutrophils, and it responds to sulfones, that is dapsone. So dapsone responding Pemphigus variant is Pemphigus herpetiformis, and it can be associated with other autoimmune diseases. Next, coming to IgA pemphigus, so this is characterized by the occurrence of IgA antibodies, whereas in other pemphigus variants we see IgG antibodies, more likely the IgG4 predominantly. But in IgA pemphigus we see IgA antibodies as well as neutrophilic infiltration. And two subtypes of IgA pemphigus are seen, the intra-epidermis neutrophilic type and the subcorneal pustular dermatosis type. So the SAPD variant here, the desmocoulin 1 is affected, and the layer of epidermis that is affected is the stratum granulosum and stratum spinosum. Whereas the in IEN type, the lower epidermis, likely the lower layers of stratum spinosum are more likely to be affected. So here the lesions in not only orbillae or vesicles, they can be pustules, and these pustules, they are arranged in an annular pattern, and they can be a central healing lesion that has crust, and this gives a sunflower like configuration, and it is most commonly seen in the intraepidermal neutrophilic type of IgA pemphigus. So the axilla and groin are commonly affected, and this is also a dapsone responsive pemphigus. Coming to paraneoplastic pemphigus, as the name suggests, it is going to be associated with a malignancy, more commonly the non-Hodgkin lymphoma and the chronic lymphocytic leukemia. And the type of lesions in the skin, they can be pemphigus vulgaris type, or they can be bullous pemphigoid like, and they can be erythema multiforme like, they can be lichen planus like, or they can be toxic epidermonecrolysis type. And the oral mucosa is involved where it presents as recalcitrant oral stomatitis. The eye can be involved where there can be pseudomembranous conjunctivitis, and the respiratory and renal mucosae are also involved, and it can present as bronchiolitis obliterans as well. Coming to drug-induced pemphigus, so two groups of drugs, thiol and the non-thiol drugs can cause pemphigus. The D-penicillamine and piroxicam and captopril of thiol group, and the penicillin, ampicillin and rifampicin of the non-thiol group are commonly suggested. And the D-penicillamine causes more commonly pemphigus foliaceus like disease, whereas rest of the drugs, they cause pemphigus vulgaris like disease. Now coming to investigations, so the management of pemphigus is a very vast topic. I suggest you read some other standard books as well for this. I'm just only going to touch briefly on what we do. So the bedside investigations, these include the Zank smear, the Nikolsky sign and Bulla spread sign elicitation. There's already a video on these. Then for confirmation, we do biopsy and direct immunofluorescence, indirect immunofluorescence, then ELISA and immune electron microscopy. DIF and IIF are more important. We see characteristic patterns like the row of tombstone appearance on biopsy, and in DIF we see a fishnet like pattern, and with IIF and ELISA we can monitor the disease activity. Coming to management, the general measures like avoiding the thiol or non-thiol drugs, and as well as treating the underlying malignancy in case of paraneoplastic pemphigus. All these general measures are very important. As well as if any secondary infections are occurring, then starting antibiotics and maintaining the fluid and electrolyte balance are necessary. Then topical drugs, we can go for topical corticosteroids. These are useful for both for skin and as well as the oral mucosal lesions. And topical calcineurin inhibitors such as tacrolimus can be useful in localized and refractory lesions. Then intralesional steroids can be tried especially in the oral mucosal lesions that are not responding to the treatment. Then systemic therapy, we can start with oral corticosteroids at a dosage of about like 60 to 80 mg per day depending upon the disease severity. It can also go up to 120 mg per day. And most important treatment regimen that is followed in pemphigus is the dexamethasone cyclophosphamide therapy, the DCP pulse therapy, where we give dexamethasone 100 mg by intravenous infusion in 500 ml of 5% dextrose over 3 hours on 3 consecutive days, and on second day we add 500 mg of cyclophosphamide as well, and this treatment is given in 4 phases. And there are also various modifications of DCP pulse therapy. And then we can also go for adjuvant treatment therapies with cyclophosphamide, azathioprine, mycophenolate, mofetil, methotrexate, cyclosporin, dapsone, rituximab, which is a really very important emerging treatment therapy in pemphigus cases, as well as intravenous immunoglobulins. Other treatment modalities such as plasmapheresis, extracorporeal photopheresis, and biological drugs such as TNF alpha inhibitors can all be tried. Thank you. Subscribe for more.